All right, good afternoon, everyone, and welcome to today's webinar on organ donation and disease transmission. We're so glad that you could all join us as we have what I'm sure will be a very informative presentation in store for us today. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to host today's program. As always, before we go ahead and get started, I'd like to spend some time just briefly reviewing a few quick notes and reminders for all of you. When accessing our webinars, we highly recommend that you use the Chrome browser to ensure an optimal visual and audio experience. If you're already using Chrome and experience any audio issues, we do recommend reconnecting to the webinar using the phone number that was provided in your confirmation email. Should you need any assistance, please feel free to contact a member from the Alliance team or send a quick note in the chat box. Additionally, throughout the course of today's presentation, your audio lines will remain muted so that we can ensure the best audio quality for our speaker. That said, we ask that you take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose your questions to our presenter during the Q&A discussion, so if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion where our presenter will address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, please note registration is currently open for our very next webinar on September 24th, which will focus on medical marijuana and CBD oil use pre and post-transplant. Be sure to join us for that this Thursday at 3 p.m. Eastern. Registration is also open for our next donation-focused webinar, which will highlight authorization strategies, getting comfortable with the uncomfortable. Mark your calendars for that on October 13th at 2 p.m. Eastern. Now, for more information on all of our upcoming webinars and to ensure you have the latest information, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we will be offering 1 CEPC credit and 1 nursing contact hour as a result of your participation. Additionally, a certificate of attendance is available for those of you who are seeking CEs that may not be offered. To receive credit, we recommend submitting this certificate to your credentialing organization as proof of participation in this offering. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If any of you are listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, Dr. Dan Leibovitz, Medical Director at LifeBank. Dan, thanks so much for joining us today. I'll go ahead and turn it over to you to introduce our speaker.
Great, thanks, Deanna. It's my pleasure today to introduce Marian Michaels. Marian is a professor of pediatrics and surgery in the Division of Pediatric Infectious Diseases at the University of Pittsburgh UPMC Children's Hospital, where she's worked in pediatric infectious disease for over 30 years with her research and clinical work largely in the area of immunocompromised hosts with an emphasis on those undergoing transplantation. Marian has also been extremely active in a number of transplant societies as well as OPTN UNOS. In fact, she's just completed her term as the chair of the OPTN UNOS Ad Hoc Committee Disease Transmission Advisory Committee, and currently serves as a new member of the board of the OPTN and UNOS. Currently, she's also serving as on the Pediatric Infectious Diseases Committee for the International Pediatric Transplant Association, as a member of the NIAID Transplant Data Safety Monitoring Committee. Additionally, she's just rotated off the board of the AST, and she remains active with them as a part of overseeing COVID-19 recommendations for donors, candidates, and recipients. I'm quite pleased to have her present on the topic of organ donation and disease transmission, and I appreciate her willingness to participate and present this conference. Marian?
Thank you so much. I'm really quite delighted to come talk about something other than COVID alone. So I want to talk today about donor-derived infections, and I've titled it Getting More Than We Bargained For. First, my disclosures and acknowledgments. I don't have any financial disclosures for this talk, but as Dan mentioned, I am a current board member for OPTN UNOS and just past chair for Ad Hoc Disease Transmission Advisory Committee. And I do want to mention that some of the work that I'm going to present was previously presented DTAC material. So with that in mind, I want to remind everyone that despite the decades of improvements that we have had with transplantation, infections still remain a major cause of morbidity and mortality after transplant. And the sources really can be multiple. They can be from the endogenous flora of the host, they can be from the environment, and certainly they can come from the donor itself. And those of you who have ever rounded with me or know me or listened to me before, I happen to like rules. And so rule number 1 is that a risk for infection exists with the use of any and all biologic agents, including organs from transplant. So my objectives for today are to review donor-derived infections, and I want to highlight infections that perhaps are anticipated, as well as those that are unanticipated, the unexpected transmissions. Talk about the OPTN UNOS rule and the Ad hoc Disease Transmission Advisory Committee in particular for how it can help with mitigating these. And then it would be impossible to do a talk without at least touching upon at the end SARS-CoV-2 or COVID-19 and the impact on donor considerations for transplant. So with that in mind, I thought I would start today with telling a donor story. A previously well but unimmunized 3-year-old girl is admitted to the pediatric intensive care unit with high fevers, increasing lethargy, seizure, and a history of having rhinorrhea or runny nose for 3 days prior to admission. Despite heroic measures, the child succumbs to a presumed infection, and the parents ask if they could donate. And the question we need to say is, can these organs be used safely? And the answer, perhaps not surprisingly, is it depends. Accepting a donor with a suspected infection is always going to be a balancing act. And there are a number of questions that we need to consider. First off, are there data to assist in making an informed decision? From the donor side, is the microbe known? Is it likely to be in the organ that is being transplanted? Because if it's not in that organ, even if it is in the person, perhaps we don't care. If it is in the organ, is the risk something that can be mitigated? In other words, can we treat the donor prior to procurement? And then we also have to look at the recipient side. Is the recipient actually at risk for this infection, or are they already immune? Can the recipient be safely treated? And what is the risk of not accepting this organ? So the other side of the balance. How sick is the candidate? If we don't accept this organ, are they going to die on the waiting list? Now, before going into a lot of details of what we know today, I think it's always helpful to remember the past and consider the history of understanding donor-derived infections. A good example of this is for cytomegalovirus. Now, CMV was recognized in the transplant era to cause severe disease, but it really wasn't until the 1970s and the 1980s when Dr. Ho and his colleagues in Pittsburgh and Dr. Dick Simmons and his colleagues then in Minnesota started to begin to recognize that actually the donor could be responsible for transmitting this virus, something that we really take for granted today. In fact, it was really with experience that this novel concept could be that a donor could transmit. So good epidemiologic studies in more recent years using DNA fingerprinting, the understanding that a microbe that could be completely latent or completely asymptomatic in the donor could cause severe disease in the recipient. And today we look at this and say, we know that it can happen and we can mitigate the situation by administering prophylaxis or monitoring for disease prevention. However, there are times that unanticipated transmissions occur, and some of them were particularly jarring. HIV transmission in the early era of testing, West Nile virus from mosquitoes to donors to the new recipients, And then there was a big game changer with that little hamster in the bottom side of the slide, where a donor had lymphocytic choriomeningitis virus from the pet hamster, went to the donor, and then to all recipients, who then passed, with majority of them passing away. I think this was a game changer. It led to the recognition that we needed to have a national group of experts to help review these unanticipated transmissions. And with that was born DTAC, TAC originally, and then now DTAC. So in 2006, Donor-Transmitted Advisory Group, which was its original name, was formed. It then became an official ad hoc committee of the OPTN UNOS as Disease Transmission Advisory Committee. And the pictures are those of the former chairs, with the person on the far right being one of my dear friends and colleague, and the current chair, Ricardo Lajos. The DTAC aims were for organ vigilance. It was to be part of the patient safety arm for OPTN UNOS and have the ability to rapidly communicate unanticipated potential donor-derived issues to at-risk recipients as well as to their transplant centers. Our job is to evaluate epidemiologic trends, provide a real-time alert for the Center for Disease Control, CDC, and public health about evolving issues, and very importantly, is to educate the transplant community and the public about risk and mitigation strategies. And finally, the last part is to inform policy and national guidelines surrounding patient transplant safety. The DTAC classification system, I think, is worth taking a moment to go over. Members of DTAC get all of the reports and review them in a confidential fashion to evaluate the probability of, was there actually a donor-derived transmission? And we put it into proven, probable, possible, unlikely, or excluded categories. I want to come back to, in the middle, that one in green called IWDT. This is intervention without disease transmission. And it's particularly useful because this is what we want to happen. We want to be able to use organs, but do something about it so that we can intervene and prevent transmission of disease, whether it be prophylaxis with an antimicrobial, or even in the case of a small renal cell carcinoma, be able to excise the tumor so that that kidney could be used safely. Now, in 2017, we felt the need to have a little more clarity in being able to educate and understand the disease transmissions. So we added a severity score to look if it was severe transmission or not severe, or if there was, in the worst case scenario, death from the disease transmission. Now, the advisory committee is pretty good. In fact, I have to say it's the most favorite committee that I've ever been on, and a shout to everybody listening. If you have any interest in participating in this, we're always looking for new people, and go to the OPTN website to submit an application. However, I do have to say it's not perfect. The OPTN policy 15.4 requires that any suspected deceased or living donor-derived disease transmission event be reported. Most of these events of transmissions are infections or malignancies. Occasionally there'll be a metabolic disease or another disease, including peanut allergy, which reminds me that I have to write that up. But it does have limitations. We don't discuss any of the expected transmissions, so you're not going to hear about the PTLDs from Epstein-Barr virus. And the system is passive, so it relies on the OPOs or the transplant centers to think, could this have been donor transmitted, so that they report it. Part of the education we take very seriously, so we do try to present at the American Transplant Congress every year, and there'll be pictures like the one shown up right now, where on the left-hand side is the type of transmission that occurred, the total number of reports, how many of them were proven or probable, how many recipients got exposed to these donors, and then what was the transmission by organ type, and how many times was there an attributable death. So we do take it seriously and try to present at multiple meetings to get our word out. I think it's worth taking a minute to also come back and say, okay, what do we screen for? Just as a reminder to everyone of what we're screening when we're looking at our deceased donors. We screen for medical and behavioral history, information that gives us some idea of the risk of a transmissible disease. We have some radiographs that can help. Blood and urine cultures are sent. Serologic and nucleic acid testing is done for some infections, but if you think about it, there are so many infections we couldn't possibly do it for all of them. But we look for HIV, we look for hepatitis B, hepatitis C, syphilis, cytomegalovirus, Epstein-Barr virus. Even Toxoplasma, which I'm going to come back to, was added in 2017 because I think that's very illustrative of some ideas. And then it's worth saying that some OPOs will think about other things as well that aren't required but are incredibly helpful, such as strongyloides antibodies from donors that are from a high-risk area, again, because we can do something about it. So let me come back to Toxoplasma. Toxoplasma, I think, is a good reminder that the transmission events do not have to be just from viruses or bacteria. They certainly can be from parasites. And while it was a recognized risk of donor transmission with heart transplant early in the transplant era, this wasn't always the case. And in fact, in the early 1990s, you really had to hunt for that information. Unfortunately for me, as a junior faculty member, it wasn't until 2 of my heart transplant recipients died with Toxoplasma that I recognized that it could have come over with an organ. Now this brings me to my rule number 2. We have to learn from our mistakes. My God, we're going to make them, but we need to learn. Learn from the mistakes, modify protocols based on new findings, and correct things. And with that in mind, starting in 1991, when my patients had this happen, we began to institute screening for all of our heart donors and our heart recipients to get screened for Toxoplasma so that we would be able to add prophylaxis if one of them was positive. Now, other organs also are at risk, not as much as the heart, because Toxoplasma, while it can go anywhere in the body, there are 3 places it likes to go. It likes to go to cardiac muscle, likes to go to skeletal muscle, and it likes to go to brains. So it is something for VCA donors that we need to think strongly about. But interestingly, the other donors could be at risk. And when DTAC reviewed cases from 2006 through 2011, there were 15 cases, some of them fatal. And when we looked at those cases, it was recognized that these unexpected transmissions generally were due to a lack of communication. In other words, the heart center knew about the Toxoplasma IgG positivity in the donor and instituted prophylaxis, whereas the kidneys didn't know or the livers didn't know. So that lack of communication here was something that you could do something about, was really problematic. And accordingly, the OPTN instituted having Toxoplasma IgG testing in April of 2017. When I last looked 2 years ago, we had about 10% of all donors are seropositive. So it is a sizable number, and prophylaxis can easily be TMP sulfamethoxazole, which can be given to prevent disease transmission. So that intervention without disease transmission that I mentioned is really what we want to go for. Now, I want to take us on a little different scenario. It's very hard to remember with COVID-19 sort of consuming everything that we do, that in fact, the United States has had some other problems, and the opiate crisis being a major one. It really exploded since 2015, showing on this graph the incredible rise of synthetic opiates over a very short period of time. Now, interestingly, the crisis is not uniform across the country. So this graph shows the organ donor deaths from drug overdose across the regions on the x-axis. The red bars are those from 2010, and the green, now a little bit old, dated, but still showing the incredible rise, is from 2016. And you can see that across the regions, there are differences in how high that green bar goes. But it goes up in all cases, and for New England, more than 1 in 4 of the organ donors are resulting from drug overdose. This is an incredible amount. And with drug overdose also comes the problem of hepatitis C infection. So these were some lovely slides that UNOS put together for us a couple of years ago to look at the problem of hepatitis C in IV drug use across the country. And just to orient everyone, the yellow is very little use, whereas as it gets darker, it's increased use of hepatitis C. And you can see as we go from 2013, 2014, 2015, 2016, and 2017, which was the last time we had this particular slide set made, you can see much more blue and green across the country, so that in New England, 20 to 25% of our organ donors were even hepatitis C positive. Well, this could be quite a problem, except luckily, at the same time, we were having a revolution in terms of treating hepatitis C. So now, a single pill could be used that was well tolerated and could actually cure hepatitis C. This truly was an amazing phenomenon, and people accordingly started to say, okay, can we use this to our advantage? So the concept of using a hepatitis C positive donor on purpose into a hepatitis C negative recipient started to be put forward. The Thinker trial from Penn and the Expander trial from Hopkins both showed that in fact this works for expanding the donor pool. And people could then take advantage of getting a transplant earlier and also maximize from having what often turned out to be a good quality organ. But what happens when it's not done on purpose? In those cases, we know the donor is hepatitis C positive. Well, this brings me back to the rules. Rule number 3 is that all tests have a limitation. And accordingly, we have to remember that sometimes a test will be negative and that a person is actually in the incubation phase, or there could just be a false negative or false positive. So I want to come back to that case of transmission of HIV in the early era of transplantation. It actually was in 1986, so a year after we started doing serology for HIV, reported in 1992 in the New England Journal of Medicine. It went from a donor who tested negative, albeit the early stage of our testing ability, but to all 4 organ recipients and 3 of the 4 graft recipients. And with this, the CDC stepped in to provide the first guidelines for preventing transmission of HIV through transplant tissue and organ donors. Well, we did pretty well after that. In fact, it was not until 2007, 2 decades later, where we had no HIV transmissions, that of course something would happen. So now, even with the modern era of testing, both HIV and hepatitis C were transmitted from a single donor, Initially, it was recognized in the liver recipient and then ultimately in all 4 organ recipients despite negative antibody testing. Likewise, not long in that same time period, a living donor who screened negative for HIV when evaluated, which was about 3 months prior to the time of donation, then had unprotected sex with a male partner in between that time and donation, and accordingly transmitted HIV. So with this, again, learn from mistakes, recognize limitations. The PHS guidelines came out for reducing now not only HIV, but now hepatitis B and hepatitis C after organ transplantation. And this is what we're living with today. The PHS increased risk donors are the term that is used, as all of you probably recognize. Now, the next graph shows that it may be time to take a change. In fact, I'm going to put forward it is time to make a change. And you can see on this graph that the donors that were called PHS increased risk over time. And in 2007, it was only 7.5% of deceased donors who met the criteria. But by the time we got to 2018, 2019, and today, 2020, it is similar, we are over 25% of all donors being classified. Well, many of you may recall that there was significant community concern that some of these donors are actually being overcalled PHS increased risk. And so we at DTAC made a specific request to the CDC to let's review, let's see those guidelines. Could we revise them to more accurately reflect the current risk based on the fact that our testing has improved substantially using nucleic acid testing being much more robust? And accordingly, as most of you know, the new PHS guidelines came out in June 26th of 2020 for the new guidelines for increased risk. The DTAC proposal aligned the OPTN policy with United States Public Health Service guidelines, are open for public comment, and I have to correct myself because I used the term increased risk, but part of the new guidelines and recommendations in policy is going to be do away with the name altogether. Okay, let's go back to our potential donor. The URI symptoms could easily be a community-acquired respiratory virus, and even if not the cause of death, one has to assume that there was a viral infection. I guess COVID-19 has to be there in today's world too, but it wasn't at the time. So what do we know about viruses? Carrie Byington and her colleagues in Utah performed one of my favorite named studies called Big Love. Had a horrible title for the group, but it allowed them to have the acronym Big Love, where they had 26 households, 108 individuals that they prospectively sampled for viruses and associated symptoms every single week. And what did they find? Well, interestingly, perhaps not too surprising, they found a lot of viruses, and there was some virus being transmitted at least 26% of the time. And it was particularly high in children who were under 5, where 50% of the weeks there was transmission, or in families that had more than 2 children, and that's shown in the upper graph, where that bottom line is 6 children or more, you were almost always having somebody who was sick in the household. Likewise, in the lower graph, there was a variable amount of shedding, depending on the virus. It averaged 1 to 2 weeks. This could also be quite high, as was seen with adenovirus. So what did we learn? Big Love, I would put forward, proved something that we already knew. Viruses are common, particularly in young children, and shedding can last a long time. And sometimes the shedding can be much longer than we can afford to wait for an organ. So I would put forward for our transplant group, do we care? Well, Again, the answer is sometimes we do. If we know there's an infection and an acute respiratory virus, maybe it's important to know what type of virus. Influenza can be very severe in our transplant patients, but there are treatments that are available. So it's a good question that Dr. Mehta and colleagues looked at by surveying transplant infectious disease colleagues from the American Society of Transplantation ID community of practice. And they put forward, what is your willingness to accept a donor if they were infected with flu by the time the diagnosis was made and by how long they were on therapy? And just to sort of highlight, if it was a lung recipient and it was less than 24 hours from time of diagnosis or institution of oseltamivir, no one agreed to accept that donor. But as you got further out, 24, 48, more than 5 days, you started to have more people who would accept it. So about a little over half of the transplant ID people said, okay, I would take that organ for a lung transplant. You contrast that with kidneys, where 93% of people would take an organ from a donor that had influenza. Well, what about some of the other viruses? Acute respiratory RNA viruses, there's so many respiratory syncytial virus, parainfluenza, human metapneumovirus. I don't have COVID-19 added to this because we'll talk about it at the end. The major risk for these viruses are lung recipients, and other organs for most of these are probably safe. Now, I'm going to say it's different for the DNA virus like adenovirus. That virus has a propensity to be in all organs, and particularly we've seen increased risk early after transplant, suggesting donor transmission. Could be reactivation, but donor transmission always is a high rate of suspicion when it's early. And the pediatric population was also particularly at risk for adenovirus, suggesting that primary infection is also of importance. So if our donor had died with a community viral infection, maybe we would accept the organ, depending on what viral testing was available. So did we know what virus it was? And also what type of organ, with the lung being the least likely organ to use compared to the others. And also, finally, again, I just want to highlight, you have to consider the other side of the scale and the acuity of the candidate. Are they at home electively waiting a transplant, in which case perhaps you can wait? Or are they in the critical care unit and you really can't afford to wait much longer for an organ transplant? So now, let's come back to our donor. What if this was actually overwhelming bacterial process because the donor was not immunized? Now, I don't have time to go through one of my other favorite topics, which is immunizations, but these are diseases that we should not be seeing today. The slides that are up here from the CDC are from the era when we didn't have the benefit of vaccination. And what you can see is that whether it's Haemophilus, whether it's meningococcus or pneumococcus, the risk of disease is highest in the young children, so like our donor. But again, I want to say we just shouldn't be seeing them. Having said that, there are a lot of studies that are out that have reported safely using organs from children or adults that had meningitis or even bacteremia. So if you know the bacterial infection in the donor, we generally can proceed with the transplant without causing harm, with a couple caveats. One, the donor should receive antibiotics prior to procurement, usually 1 to 2 days a minimum, and also that the recipient receive appropriate antibiotics after transplant. Okay, having said this, I want to remind myself and you not to be so cavalier, because things move forward and we are now living in the era of antimicrobial resistance, and this has impacted transplant often with dire consequences. Dr. Mehta's group also looked at whether the transplant ID people would accept an organ from a donor with known bacteremia based on what type of organ and what type of infection. And to highlight, if it was streptococci, like an alpha strep or strep pneumoniae, almost everyone would accept it for all organs. On the other hand, if it was a carbapenem-resistant Enterobacteriaceae, very few transplant ID doctors would accept them. Now, Stephanie Pouch, from one of our DTAC members, took it upon herself to look at the potential donor-derived gram-negative rod transmission events between 2012 and 2018. There were 80 case reports with 92 recipients. In those, when we looked at the proven probable in the lower left-hand corner, 33 donors were used with 49 recipients, and 6 of the patients died. Unfortunately, when we get our reports, we don't always have susceptibility data, so I don't always know if they were from resistant organisms, but it's still an area that we have to take seriously and follow. So I want to come back one last time to our donor. Could this actually be encephalitis? And I would say yes, depending on the geography and the time of year. If it's summer when mosquitoes are flying about and biting us, or you live in an area where there are mosquitoes all year round, and also what potential exposures that child had, this could be an encephalitis. These are the type of things that we never want to have spread across the Evening Standard or the New York Times. Dr. Dan Call, who was one of our former chairs of DTAC, took it upon himself to look at donors with CNS infections. Of the 91 reports, 12 donors were proven to have central nervous infection, and 6 of them never transmitted at all. But 6 of the donors did transmit to 10 of 15 recipients. So if it is transmissible, it has a high rate of transmission. And 5 of the 10 recipients, so a full 50%, died from the infections. This was felt to be impactful enough that DTAC came up with guidance documents so that potential donors with initial presentation of fever and an unexplained or poorly explained neurologic process, like a 30-year-old having a stroke, should be evaluated more intensely for possible encephalitis or meningitis, and consider these donors with increased caution. And the use of these organs we would put forward should be discussed with a transplant ID physician. And we're just writing up the paper on cryptococcal transmission, and so many of these donors had central nervous system symptoms when you went back retrospectively, and you just wanted to say, I wish they had done a cryptococcal antigen, because again, we could have given fluconazole or amphotericin products to have prevented transmission and often death. So I know I've talked a lot about a significant amount of infection, so that it might seem a little fearful. But when you think about the whole scheme of transplant, where we have over 10,000 donors a year, the transmissions are actually relatively rare. So in blue, we look at about 400 cases each year. Around 250 to 270 of them have to be reviewed by DTAC, but only a small portion of them in orange actually come down to fully proven or probable. Having said that, any death that happens is too many, and particularly when we have the ability to prevent something by intervening, I feel like we need to do that and keep an eye on these disease transmissions. Okay, with the last 5 to 10 minutes, I did feel that it was important for us to talk about SARS-CoV-2, the virus that causes COVID-19, and the impact on transplant. And you know, I feel like my world has become pre-COVID and after COVID, and I'm sure that's true for many of you as we all get used to the virtual sense of reality. It's almost impossible to remember that it really was just the end of January when the report of this novel coronavirus came into preprint from the New England Journal, when the doctors at Wuhan, China, described a small cluster of patients with pneumonia who were admitted in December of 2019 and had in common being involved with the animal or bird market or seafood market. From there, at the end of January, we started to see cases. At this time, January 31st, there were less than 10,000 cases, mostly clustered in Asia. But by yesterday, now over 30 million cases clearly across the world. And I'll tell you, I will always remember that stark Sunday when I picked up the Sunday New York Times, May 24th, and the front page and the subsequent pages were just lined with name after name and a little tidbit about the person so they wouldn't be considered just a statistic. At that time, there were nearly 100,000 deaths, and now we're up to near 200,000. I'm not going to talk politics other than to say we should have done better. Now, as chair of DTAC at the time, I really felt pressure and the importance that it was imperative to get something out quickly to the community. And, you know, even though we didn't have a lot of knowledge, at least to say, let's have a context for how we think about this, how we move forward. Unfortunately, everything needed to go through a very intense review process, and the government was not so nimble as to be able to do that in a fast fashion. So I quickly solicited the help from my co-chair, Ricardo, and former chairs to put an article out where we reviewed, in theory, what the risk would be and the concerns. How fast time moved. Within 8 months, there are now over 400 articles in PubMed when you put in SOT and COVID-19. But I want to just highlight, when there's such pressure to get things out so quickly, that some of these articles are also retracted. So it is important to sort of keep an open mind and be on the lookout for confirmation of studies. So what were the concerns? We certainly had concern for increased severity in solid organ transplants, as we've seen with many other RNA viruses, such as influenza. It does appear to be the case, although not always transplant per se being the risk, but sometimes the cofactors like diabetes, renal disease, or even obesity. We also are concerned for the risk of nosocomial exposure and transmissions to our patients' families and their close contacts, and even to us, to the transplant and recovery centers, to the OPOs, to the healthcare workers. And then at the time, there was also the concern for, could there be donor transmission? The virus clearly has been found by PCR in blood, in stool, and less commonly in other organs, but does this actually translate to infection? Luckily, at the moment, we have not seen donor transmission, but the numbers are very small. We're just working on a paper right now with the CDC looking at the first 8 cases that came through, and in all of those cases, none of them could say that they were definitely donor transmitted. But I have to remind everyone that our ability to test in the early days was actually quite sparse, which was a big problem. The UNOS database is incredibly helpful, and you can see where I've circled that these are the number of transplants that take place by week, and there was a sudden drop, and in particular, that drop more than for deceased donors was in our living donors transplants, where centers had to shut down because we didn't know if we could do it safely at the time. The American Society of Transplantation really took a brilliant lead on trying to get the data out and being very collaborative with other groups, including with UNOS. I was on the board then too. In fact, it was wonderful. It was the only time, just by chance, there were 3 board members that were transplant infectious disease physicians, including our president, Emily Blumberg, who just took this to heart with the lead and put out webinars and information, which we still have on the website and that you can access. When getting ready for talks this week, I realized that we were a little bit behind. We had been updating them weekly in the beginning, but we're in the middle of updating them this week as well. So where we are at this point in time with screening donors is that all donors should be screened for known exposures, for compatible symptoms, and virologically. And currently, we would recommend not using a donor that's COVID-19 positive by nucleic acid from the nasal or oropharyngeal sample. But you could imagine, as the folks in Seattle put forward in a recent American Journal of Transplantation editorial, is there a point where maybe we could use them for some organ recipients? We're not there yet, but we may be in the future. So just to conclude, I am going to put forward that there is always a risk for infection. We have to learn from our experience and modify protocols and procedures, improve our strategies for identification, prevention, and management, and always consider the unexpected and ensure that the candidates are educated about risks prior to transplant. And with that, I would love to thank everyone. There's a picture of my hospital, Children's Hospital, on the top right in Pittsburgh. On the top left is Children's Hospital in Pittsburgh on the right. And then because I've used so much of the DTAC data, I wanted to put up my colleagues and members from DTAC. Thank you, and I would be delighted to take questions.
All right, thank you so much, Dr. Michaels. We're going to now go ahead and open up the floor for questions, but before I turn it back to Dan to facilitate the Q&A discussion, I'd just like to remind everyone that if you do have any questions for our presenter, please be sure to submit them using that chat feature. Just as a quick reminder, that's going to be located on the bottom left-hand corner of your screen. Additionally, during the Q&A session, I'm going to have this poll up, so for those of you who may be participating as a group, I'd like to ask that you please complete this poll and just let us know how many people are participating in your respective group. That being said, I'll go ahead and turn it back to Dan. Thank you so much.
Great, thanks. Well, Dr. Michaels, that was an outstanding talk that I really enjoyed, and I found myself just writing question after question down. So if nobody else asks questions, I've got enough to probably fill up another hour. I'm going to go ahead and start while I'm waiting to see if there are any questions. I was intrigued by your comment about a peanut allergy transmission. Can you give us a little more information about this?
Sure, I would love to, especially because as I was talking, it was reminding me that I do have to write it up, as I said. So the peanut allergies, it was really intriguing. It appears to be most impactful for lung recipients. So we had a couple cases where a lung recipient who never had a peanut allergy before goes ahead, takes a Snickers or a peanut butter cup or something, and in a couple cases actually anaphylaxed, and unfortunately a couple cases actually died. When you went back to the information from the OPO, in fact, the donor had a peanut allergy that was severe. This also seemed to be able to be transmitted to the livers. And when we thought about it, you think about all of the lymphoid tissue that comes over with a lung, with an intestinal transplant, we just don't do that many intestinal transplants, but next with the liver, that we think it's because of the lymphoid tissue that's coming over that's probably leading to that transmission. I've talked to a lot of my allergists, and we wonder if you got through the first year or two whether in fact that would go away. But I think the important thing is that if I have a donor that has a peanut allergy, and in several of the cases the donor died from anaphylaxis from like a peanut allergy, so a very severe peanut allergy, then I think your recipient should at least be tested by allergy and have an EpiPen. That would have been life-saving. So really intriguing.
Yeah, that is fascinating. Did you happen to see whether there's anything about patients with a history of asthma that transmit asthmatic kind of lung phenomenon?
Yeah.
Through transplantation?
No, that's a fabulous question. Could other things be transmitted like penicillin allergies or asthma? And I think part of the problem with that is that we don't always have the ability to look for it unless the recipient center contacts us and says, could this be donor? And I think when you think about it, asthma is so common, and also penicillin allergies, for example, are so common that if you had a recipient that post-transplant develops an asthmatic event or a penicillin allergy, you wouldn't go back and think, oh, could that have been donor transmitted? It's probably just their own allergy. So I think the problem is it brings up the passive nature of DTAC that we really couldn't get at that information. But great question.
So I'm going to just dive into the COVID-19 issue. Did I hear you correctly when you said that there had been 8 case reports presented to DTAC about COVID-positive donors?
Yeah.
Is that what I heard?
Let me come back. Actually, the case reports are about a recipient early after transplant who was COVID positive, and in one case, a donor who was noted to be COVID positive. But this is going. We've actually had more cases reported subsequently, but we still don't have any cases that really are a trigger that we've transmitted it from the donor. Those early cases, the donors weren't tested. We didn't have testing. I mean, it's hard to remember back, right? We didn't. I mean, I still don't have enough tests for me clinically to, in the Pittsburgh area. I know it varies substantially depending on where you live, but in Pennsylvania, we are still having a dearth of tests available to us, which is a real problem from my standpoint as an infectious disease doctor. But in the early era, the donors that were being used were not tested. And in fact, it wasn't until even April when I went back through our recommendations from the AST Society that the donors be tested by nucleic acid testing, because we knew it wasn't available. If we said you had to test, we were going to stop transplantation altogether because we didn't have the ability to do the test. So the 8 cases that we looked at, it was because of a recipient. So then we went to look at the donors. Unfortunately, no one stores saliva. We weren't even in most cases able to find any bronchial wash material. So it does bring up the limitations that we have of being able to go back. But we didn't find other recipients that were positive at the same time. There was a case that's already out in the literature, so I'm not giving any confidential information out. There was a mother who donated to the child a liver, and both of them ended up with COVID shortly thereafter. Now the kid did go to the ICU and did have some findings in the liver of hepatitis. So could it have been from the donor? I'm going to put forward there's a possibility, but there's no way to know because we have no samples prior to transplant.
Well, thanks for that. There is a question from the audience. Emma Daniels asks a question wondering if programs should consider testing potential living donors for COVID-19 antibody.
That's a great question. We've debated that back and forth a lot. I think from a research side, I would love to have living donors tested. I'd even like to see recipients tested as well, or candidates, I guess, tested. But at this point in time, I don't know how to interpret it. I don't know whether I can say if that donor, living donor, has COVID-positive antibody, does that mean there can't be any viral particle that could be transmitted or not? So I don't know how to do the interpretation. Having said that, I do think that living and deceased donors should at least be tested by nasal swab or saliva swab. And for lungs, if they can get a bronchial wash, I think that's the right thing to do.
Another question's popped up on the list. Nicola Ehrenberg says about peanut allergies, any cases of rabbit allergy with the donor at our center? We use thymoinduction for some recipients. Could rabbit allergy from a donor be transmitted?
That's a fabulous question. I can tell you that I have not seen that come across from the 7 years that I've been on DTAC, and we just did a 10-year review that got published in AJT. Dan Call is the first author, and rabbit allergies or animal allergies have not come across. But again, if no one reported it, we wouldn't know to look for it. We wouldn't have the, so it really has to be if you have a transplant where you have a new onset of an animal allergy after transplant, whether it's rabbit, cat, or dog, then I think it would be reasonable to say, hey, will you guys look at this? Because then we could go back and look at other centers, and more importantly, be able to tell other centers, be on the lookout for this, and look also for the allergy having been in the donor. Thanks.
Excellent. So I have a question about CNS infections. In the last few years, we've started running a PCR encephalitis meningitis panel that gives us rapid results. Are you utilizing that on those patients that have these unexplained or potential CNS infections, and you're trying to determine whether or not they're suitable for donation?
Well, that is a fabulous question. So the meningitis panels, and there are several of them that are available. The California Encephalitis group does a number of antibodies on CSF and on the blood, and you have paired samples, etc. Unfortunately, they are incredibly expensive, and they're not always so sensitive. Now, when we have transplant recipients who end up with an encephalitic picture, we usually have been able to convince the people who are in charge of the finances of the hospital that it is worth testing because the need to know is there. But, and I guess let me come back. Were you asking, do we test the recipients? Because, yes, we do. There are
the donors,
patients.
when we're
the donors.
Right, no, I was speaking specifically about the donors because we rule out. From a medical director standpoint, I can tell you that I at least rule out a number of potential donors with an unexplained encephalitis if I don't have an organism. So I've tried to use these PCR panels to identify, if possible, an organism, bacterial or viral, to give me at least a cause or a potential cause that I can then transmit on to the potential recipients and the recipient surgeons. Yeah.
So that's fabulous, Dan, that you're able to do that. The clinical cost is so abhorrent that I would think it would be hard to do. Now, it's not something that I'm against doing by any means, and some of the cheaper things like doing a cryptococcal antigen I think is worthwhile in these cases as well. But I haven't been seeing a lot of donor samples using that, but that's really interesting and might be something we should explore more. Same thing, I know my pulmonology people are very interested. If you're having a lung transplant, should we be doing the multiplex PCRs looking for RNA viruses? And I think that probably because of COVID, I bet that'll happen in the future on the bronchial wash.
Great, thank you.
Interesting.
So along the lines, I've got another question along the lines of the lung transplant. In terms of antibiotics, you talked about if there's a potential or possible infection, then giving antibiotics up front may be helpful. Do you do you recommend on any potential donors starting prophylactic antibiotics routinely, or do you only do it if there is a known infection?
Mm-hmm. So I personally don't get asked about the donor. My recommendation is that I would do it if there's a concern for an infection, if there's a known infection, and sometimes I do get asked about a person who ultimately will become a donor because they're in my intensive care unit. And there I feel very strongly, despite immunizations, not everyone, the meninge vaccine isn't used as widely and only used at certain ages. So meningococcus we see. And those are organs that we can use if people have been on antibiotics. Same thing with pneumococcus and even staphylococcus. So if we know that there's an infection, I would use it. Now, having said that, I very much worry about antimicrobial resistance, and I've heard of some OPOs being told by centers that they don't want to use the organ if they're not on something like meropenem. And that to me is really scary, because I think we're going to promote resistance, so I would not use it willy-nilly.
Okay, well, thank you. It looks like we're at the top of the hour. Am I correct, ladies, that it's time for us to sign off then?
Yeah. Yeah, if there are no more questions, I'd say we can look to wrap up.
It seems like there are no more questions on my list, so I'm going to once again thank Marian Michaels very much for an excellent talk. And encourage anybody that has more questions for Marian to please send them on to the Alliance, and we'll forward them on to her and put you in direct contact.
Well, thank you, everyone.
Back to you, Deanna.
Thanks, Dan. I just want to, on behalf of the Alliance, just echo Dan's sentiments. Once again, thank you, Dr. Michaels, for such a fantastic presentation. And additionally to you, Dan, a huge thanks for your facilitation of today's discussion and presentation. So thank you to you both for your time and participation today. And, of course, to our participants, as always, we thank you for joining us, and we hope to see you again in the future. Enjoy the rest of your day, everyone.